Hi everyone, this is Neel Raithatha here, consultant, audiologist and director of ClearWax. Thank you for joining me in this very interesting case using both the wax scope and the iClearScope endoscope of a patient with a grade 3 Keratosis Obturans. Now, if you're watching on YouTube, I know some of you don't, on the Wax Whisperer YouTube page, don't like the wax scope, hence why I've got another dedicated YouTube channel purely for the wax scope, but here I'm using both and probably in equal quantity, so do stay tuned. It's a really interesting removal of a patient's Keratosis Obturans. So to give you the backstory, and you may have seen a moment ago, I did include a still image of the dead skin that I removed, a dead epidermal plug, which is the basis behind a Keratosis Obturans, and I'll explain that in more detail as well. And I'm going to include it again at the end of the video. So this patient actually saw a colleague of mine. My colleague is Maxwell Vokes, is a very good hearing aid dispenser who works for Correct Hearing in Nottingham, and he's become very skilled at wax removal. But he saw this patient on a couple of occasions, and whilst with the patient on the second occasion, contacted me. Fortunately, I was able to take the call at the time and advised that he thinks this patient's got a Keratosis Obturans, and wondered whether I would be able to see the patient and whether he would also be able to come along and watch me attempt to remove. And I said, that's no problem. So this patient attended, I think 2 or 3 days ago. Now, in terms of age profile, this patient was in their mid-30s, which is the peak decade for someone developing Keratosis Obturans. They also presented with very acute otalgia, so very not a dull pain, but more of a sharp, severe shooting pain, which is again characteristic of a Keratosis Obturans. And of course, they weren't able to hear. So what is a Keratosis Obturans? Now, a Keratosis Obturans is an abnormal accumulation of dead skin, and that skin is the outer layer of skin, the most superficial layer of skin that lines the ear canal. So it contains keratin. Keratin is a protein that's also found in our fingernails and hairs. And one of the unique characteristics with Keratosis Obturans is that the plug forms almost like an onion. And what I mean by that, in onions, you've got layers. And here, and you're going to see it, and it was particularly with the wax scope, and you'll get some good images in a moment, but you have rings of skin, long sheets of skin that are interconnected, and they form in layers, just as it would with an onion. We call that lamella structure. And you can see that there. You've got a bottom layer of skin separated, and you're going to see it more and more during the course of the video. And Keratosis Obturans, so it's not earwax, it's formation of dead skin. So I'm just trying to use the forceps. Now, forceps are not always good with Keratosis Obturans. Again, I'll explain why that is during the course of the video, but I thought I'll give it a go at this stage. And this keratin plug, so it's almost like a rubber ball in terms of consistency. So it's springy, almost like a rubber band. When you pull it and then you let go, it springs back. It normally forms in the osseous portion of the ear canal, so the bony part, the inner 2/3 of the ear canal. And it's estimated that about 4 to 5 cases per 1,000 who attend audiology or ENT present with this. I think it's a bit more, personally, but sometimes people misdiagnose this for earwax. Now, in terms of if it happens in one or both ears, 50% of cases occur unilaterally, so in one ear, and the other 50% bilaterally. And as mentioned at the beginning of the video, it's most common in patients below the age of 40. And ironically, females are purportedly more prone to developing this than males. I don't see that myself in clinic, but that's just an anecdotal finding. I actually think it's probably an equal split. If anything, probably I see more male patients with it. Some of the risk factors of developing Keratosis Obturans is bronchiectasis or sinusitis. And the rationale behind that is that when you've got bronchiectasis or sinusitis, it stimulates the reflex sympathetic system of our body, our nervous system, and which then causes the dilation of blood vessels, in particularly of the sebaceous glands in the ear. For that reason, that's one of the reasons why younger patients possibly are more prone to this. So again, it's purported about 80% are pediatric cases and 20% adults. And I'm not sure anecdotally I see that in clinic, but it's possible that the pediatric cases, they are straight referred to ENT. So we don't particularly see them. I see a few, but mainly more adults. So I've discussed some of the symptoms already. So it's acute rather than dull pain, conductive hearing loss. In really severe cases, patients can develop facial palsy. And that's because the facial nerve runs posteriorly of the ear canal. So if this invades that area and causes a lesion of the facial nerve or compression, it can cause facial palsy. And in the very, very extreme cases, it can cause dehiscence of the tegmen tympani. Now, the tegmen tympani is a thin plate of the temporal bone, and it acts like a roof separating the middle ear, so the cavity behind the eardrum, and the intracranial compartment where the brain is. So you can see there, it's like a string of blood, and I'll explain what that is. Now, just to let you know, this is the upgraded version of the wax scope. The wax scope previously was incorporating the iPhone SE, the third generation, but that's now obsolete. So the new iPhone that's meant to be the direct replacement is the iPhone 16e, and I think it does give a bit more of a crisper image, although the previous wax scope with the iPhone SE was particularly good already. Now, one of the other hallmarks of keratosis obturans is this global widening of the bony part of the ear canal. We call that process of this widening remodeling. And the reason why that occurs can occur for two reasons, really. It could be the pure physical pressure of this plug of dead skin. And that just gives you an idea of how much pressure this rubber ball of skin, I'm calling it a rubber ball because it has that consistency, it's very springy, as you can see at the moment. And the pure pressure can cause a widening of the ear canal, but more so it's due to a process called bony resorption. Bony resorption is when bone tissue is broken down and dissolved and released back into the bloodstream. And this process is as a result of specialized bone cells called osteoclasts. So osteoclasts are specialized bone cells that are on the surface of the bone, and they break down and dissolve the outer layer of bone into these core minerals and tissues, redistribute this broken down material into the bloodstream to new parts, other parts of the body where new bone is formed, and new bone is formed via specialized cells called osteoblasts. This process is vital because it ensures that this recycling and redevelopment of bone is important, because it just ensures the bone is got all its integrity and strength. Sometimes you can have bacteria, for example, living on the surface of the bone, which weakens the bone. So by the bone across the body continuously recycling itself, it just ensures its integrity. So the bone itself is not eroded. So eroded is more so when there's diseased bone, so like a decay of the bone. We call that necrosis. For example, when you have external auditory canal cholesteatoma. And importantly, with the keratosis obturans, there's no ulceration. This underlying skin is still lining the bony part of the ear canal. And the widening is typically global, and what I mean by that, it's all the way around the ear canal. With other conditions like external auditory canal cholesteatoma, which I just made reference to, you have more localized lesions of the bone, and you do get ulcerations of the skin, and you typically get discharge, the infection there. There's another condition called benign osteonecrosis, and that's where the bone decays, so there is necrosis there. And that's due to a lack of blood flow, and that typically clears the floor, the base of the bony part of the ear canal. Typically with that, the skin is more often than not intact, but you can get cases where the skin is again ulcerated. So there's three conditions there that it can sometimes be misdiagnosed for one another. Typically with a grade 3, which is what we've got here, you do get bleeding, as you can see. Now, this bleeding is not because I've grazed the ear canal or caused any lacerations or iatrogenic trauma. It's because we're removing this matrix of newly formed blood capillaries. So when you've got a keratosis obturans, it's compressed so much against the ear canal wall, it causes inflammation, and the body then produces what we call granulation tissue. So granulation tissue is inflammatory tissue, and it's essentially formed of connective tissue, but it undergoes a process of neovascularization, so a formation of new blood capillaries. So when you start removing the keratosis obturans, you're rupturing the granulation tissue and these newly formed blood capillaries. So we call it contact bleeding. So you'll see a lot of bleeding. And again, that's a hallmark of a grade 3. Quite often as well, you can get inflammation of the ear canal laterally to this epidermal keratosis plug. And so what I mean by that, so the plug of dead skin is typically in the bony part of the ear canal, so it's deeper. And in front of that, there can be inflammation there. So, and swelling and edema. So sometimes that can give the appearance that the ear canal is wider than it actually is. So that remodeling process, because it's kind of like a pseudo widening, you're comparing the lateral part of the ear canal, which is kind of slightly inflamed and there's a lot of edema there. And so automatically it makes the deeper part of the ear canal look wider than it actually is. But quite often there is, again, remodeling of the ear canal. Keratosis obturans, you have different severities. So some goes from grade 1 to 4. Grade 1 patients, so initially my colleague Max thought this might be a grade 1, but as soon as we started to remove it, it was very apparent it was a grade 3. So grade 1 is when a patient attends with mild pain, mild earache, and there might be a mild expansion of the ear canal, so a widening, but not always discernible. A grade 2 is when a patient presents with moderate to severe pain, and there's mild widening of the ear canal. So this patient did have moderate to severe pain. They've been on painkillers for the last couple of weeks. A grade 3, similarly to a grade 2, you do get moderate to severe pain, but the widening of the ear canal is more exacerbated, so we call it probably a moderate expansion of the ear canal. And there is granulation tissue, normally at the osteocartilaneous junction where we are now. So at this point of the ear canal is where the canal, the cartilage portion, so the outer third, meets the inner 2/3 of the ear canal, the bony part. You can see the canal there to the right, that's the cartilage, and just where it widens, that's the bony part. Then a grade 4, and I have come across a grade 4 once, and they needed surgery. And that's where the patient comes with severe pain and widening of the ear canal. So much so that it can cause what we call an automastodectomy. So there's a surgical procedure called a mastodectomy, and that's when the bone behind your ear canal, so posterior to the ear canal wall, is surgically drilled away or widened and removed because it's infected. So when you look in a patient's ear with a mastoid cavity, a mastodectomy, the ear canal is huge because it's not only their original ear canal, but the ear canal now merges into the mastoid bone, so it's like a huge cavity. And these are the cases where sometimes patients can experience facial palsy, because the facial nerve just runs at the back of the ear canal, as I mentioned. So when ENT surgeons perform a mastoid surgery, they're careful, they create a ridge. It's a facial nerve ridge, so they don't drill the bone below a certain point because that's where the facial nerve is, so they keep that intact. Causes for keratosis obturans are patients with eczema or seborrheic dermatitis, which is actually a fungus that is on our, typically grows on our scalp, and dogs and cats normally have this particular fungus. Furunculosis or chronic inflammation. So a furuncle basically is almost like a pimple that can occur in the ear. There's kind of an umbrella term, if truth be told, but it could be a blood-filled blister, for example, or pimple, or pus-filled. But more typically, it's due to chronic inflammation of the ear canal, which results in increased blood flow to the ear. And the more blood flow you have going to your ear, the more skin that the ear secretes, and the more skin that the ear secretes, the more dead skin that it produces, and then the skin can... So your ear is designed to shed away and expel dead skin, but if your ear is producing it at a quicker rate, then it can naturally expel it. You're going to get an accumulation of plug. And also an abnormal migration of skin. So as I just alluded to, the whole ear canal, including the outermost layer of the eardrum, is lined with skin, epidermal skin. And as that skin dies and sheds, it moves sideways. We call it the lateral epithelial migration, and compared to the great wildebeest migration. So the skin from the eardrum, as it's shedding, it moves across the eardrum radially. When I say radially, if you imagine you've got a little pond or a pebble and you drop a pebble at in the middle of it. So I was meant to say pond or puddle, not pebble. And you drop a pebble in the centre of it, you get this ripple effect. Similarly, the skin is formed at the centre of the eardrum. That's the progenitor site where the umbo is. So the umbo is a section of the hammer bone, the malleus, which connects to the eardrum in the centre. Almost thinking almost like a bullseye. And that's where epithelial skin is produced. And as it's produced, as it starts to migrate, it migrates radially across the edge to the eardrum, and then it slowly makes the process from the deepest region of the ear canal to the entrance. The rate of migration, it can vary, but it's probably about 3 millimeters a month on average. Now, as the outer layer of skin, of course, you've got individual skin cells and they're interlocked. And as the skin reaches the outer third of the ear canal, the interlocking of the individual skin cells falls away, which means the individual skin cells are no longer interconnected and it starts to flake away individually. We call that desquamous epithelial skin. Now, that I've just described the normal migration of skin, but in cases of Keratosis Obturans, sometimes the skin can migrate more inwards to the centre of the ear canal as opposed to out of the ear canal, and it can form into this plug. So, as mentioned, inflammation is a big cause for Keratosis Obturans because inflammation increases vascularization, so blood flow, and it could be due to an acute infection, so a viral infection even. So, I mentioned before patients with sinusitis and bronchiectasis, because that increases inflammation. So the more inflammation, blood flow, you get epithelial hyperplasia. So it's this additional excess epithelial skin. And those kind of cases are normally singular, so it's a one-off event. But then you get the more silent type, which is more to do with the abnormal separation of the skin and the migration of skin, as I described earlier. So normal skin in that lines the ear canal. As the shedding process, it moves sideways from the deepest part of the ear canal towards the entrance, and when it reaches the outer third of the ear canal, the interlocking dead skin cells separate and they flake away. But in cases of Keratosis Obturans, you have this abnormal migration where the skin migrates inwards as opposed to outwards, and the individual skin cells fail to break away. They're still interlocked, hence why you get this lamellar structure, this onion layer. And in terms of treatment, for the chronic forms of the silent type, it's regular cleaning. Anti-inflammation drops. I know some ENT prescribe steroids to reduce inflammation and therefore blood flow. And then sometimes patients for really severe cases can go surgery, so they can have split skin grafts. What that's designed to do is to reduce the widenings of the ear canal. So ideally you want the ear canal from the entrance to the eardrum to be more or less similar in diameter. Now that's not, even in a normal ear, that's not the case, but by making it more similar, it helps the skin to naturally migrate outwards. When you've got this massive widening in the ear canal, think about it like a well. The skin's going to fall into the widening and fail to come back out, and it can form into a plug. So yeah, split skin grafts to reduce the widenings, or a canaloplasty to widen the narrower parts of the ear canal to almost be similar in diameter to the widening. So you can either reduce the widenings or increase the narrowings. Ultimately, the overall aim is to get the ear canal diameter more or less similar from the entrance to the eardrum. Now, I think I'm going to revert to the iClearScope in a moment, but again, you can see that layer of skin at the bottom. And let me talk about the technique with the Keratosis Obturans. I should have mentioned it right at the beginning, because there's probably going to be a few comments now that I can potentially could have avoided. Keratosis Obturans is the hardest thing to remove from someone's ear. It's not an easy process. Typically, if you look on my YouTube channel, I've got a playlist of Keratosis Obturans cases, and they can take 30 to 45 minutes. And that's the norm. There's no kind of shortcut really. And that's because, look, for example, I'm using forceps here. I'd used it right at the beginning. It didn't do much. When I used the ear hook or the curette, it just cut through it. It sliced through it. Here, you just have to work at peeling it away from the canal wall. But it's so adhered. And again, with another thing I mentioned, another hallmark of Keratosis Obturans is this peripheral silvery matrix. So as you can see here, so this matrix of white silvery skin that surrounds the plug, and this skin is the newer dead skin that's undergoing the shedding process, but it's not quite there, so it's still attached to the ear canal. So you just have to work at peeling it, and it springs back. I made the analogy, it's like a rubber ball or rubber band, almost like a trapdoor. You lift it up and it springs back down. There's so much connective energy because this skin is somewhat coiled as well. You've got so much connective energy. When you lift it and let go, it just springs. So it's a matter of patience and perseverance, and we're just going all the way around. So you can see here, I'm just pulling and pulling, and I mean, my colleague Max, who was attending, was watching, and you could see how much force I was applying. So I'm not being reckless at all, but I was applying a lot of force, but directed force. We know where we're applying the force. And truth be told, I was shattered after the appointment because I had a patient before this. They had another, not Keratosis Obturans, but they had both ears full of matted, mushy wax all over the eardrum as well. And that has its own technical issues and challenges. And so I was with that patient for about 45 minutes straight, both ears. And then I had this patient. But with this patient, I did allocate. Our appointments are normally half an hour, but because it was suspected Keratosis Obturans, I did allocate additional time just in case. So the reason why I reverted to the eye clearscope at this stage, we're halfway there, but with the endoscope, and this is where no other visualization method can begin to compete with an endoscope, is that it's wide field of view. Because we've got this widening, as you can see. So I've basically used the wax scope to loosen the peripheral plug, trying to peel it away. And the benefits of the wax scope is just the magnification and the clarity. So it really enables me to work really, really closely to the ear canal. And once I've felt peeled that away, I've then gone to wax scope to finish the job off, if you like, because I can see much better into the widenings. When the widenings are full of dead skin, you can't really see into it because you're just seeing the dead skin. But once you start to peel that away and start removing this dead skin, you can actually see into the widenings. Not to say you couldn't do it with the wax scope or an ENT microscope. I mean, this kind of case, you just wouldn't even dare, in my opinion, with a head-worn Lutz microscope, head-worn microscope. You just haven't got the magnification, and you haven't got the field of view, so you're limited in two ways. So it's not to say I couldn't continue with the wax scope or the ENT microscope, but I've got the endoscope at hand, so it's going to give me a much better view of the widenings. And you're probably starting to see that now because we're clearing this. You can see now this is the widened area. And I don't know if you can see to the right of the suction tip, you can see like two layers of skin there. The skin, like the sheets of skin. So there again, that's that lamella stretcher. I'm really tugging away. So I've used the ear hook already. I used the ear pick as well. I think I used the curette as well, all at the beginning. And they were just cutting through. But when I used the ear hook, although it cut through, it did start helping me to remove it, because when you cut through it, you're kind of separating some of the skin. You're creating space in the middle of the ear canal where when I'm trying to peel the plug off the canal wall, I can go inwards to the midline. If the middle part of the ear canal is full of the dead skin, when I'm trying to bring the dead skin from the peripheral part of the ear canal to the midline, there's no space because you've got the plug of dead skins there. But when you cut through the middle, you can start bringing it in. So again, I'm just peeling from the top. You can see that granulation tissue. So again, we've not caused any trauma. This is inflammatory tissue, and it's got its own blood capillaries. It's undergone a process called neovascularization. I'm really, really tugging at this. The problem with forceps, it just cuts into this skin, doesn't remove it. Now, if you were to kind of somehow freeze this epidermal plug so it's kind of more rock solid, and an ear hook, ear pick, or the forceps might be more beneficial, because you're not going to, well, if you make it too cold, you might make it brittle. But when it's soft like this and springy, you're just stretching it and cutting it. Again, I can feel my hand tiring at this stage. I was really, really working at this, really tugging away. You can see that circular motion I'm applying with the suction tip. And that's the entrance. I'd actually had to come away there because my hand was shattered. Shook my hand a little bit, get the blood flowing again, and then back in. And now it's starting to come away. And it comes out in a long tail, I think. And I thought this was all of it. I mean, we got a lot of it out already. It was with the wax scope. It was being suctioned up the tip, or some of it was stuck to the end of the suction probe, and we removed it. So we still got some more skin. This is right near the entrance. They also had quite a bendy ear canal. The first bend was quite bendy, so that makes it a bit more challenging. I didn't notice it as much with the wax scope, because with the wax scope, the specular is almost stretching and straightening the ear. But with the endoscope, you could tell it was a bit more bendy. So we're still working away, and you can probably see those ribbons of skin now. There's lamellar layers. It's surrounded by this silvery white matrix, which is all characteristic of a Keratosis Obturans. So we're still not done, although I've got the plug, and the patient could hear so much better already, but they still felt there's something in the ear, and I had to say, yeah, you're quite right. That was some granulation tissue that got vacuumed up, actually. Now, this is just more layers and sheets of dead skin. And it actually comes out in a nice piece, but I had to work. I think I'm going to have to go back in a moment. You can see those sheets of skin again, just to the left, where it's folded over itself, but there's still a lot of skin. Still can't fully see the eardrum. So I'm going to go back in. Just going to make contact. I'm just going to lift it up, just going to keep the suction probe there to generate some suction power. I'm just looking for a piece of the wax to suction on, because initially it was kind of, I felt it was pushing the skin in as opposed to getting a suction grip. I think this is teared away. And they've got a lovely healthy eardrum. Sometimes with Keratosis Obturans you can get a thickening of the eardrum, the outer layer, the epidermis layer, because you've got excess keratin in the skin cells, but not so much here. And you can probably start to appreciate more how wide this ear canal is. I think this is just some granulation tissue and some skin attached. This was a very thick, very, very thick layer of skin. It's quite difficult to remove this, actually, but we managed it. So I'm working up and down, trying to just separate it. Just tugging. Again, I didn't go back in with the forceps because it didn't really work so well. It probably would have worked with this piece of skin, if truth be told. But I just continued with the suction and managed to peel it. Good thing about suction with this dead skin is that you can see I'm peeling it toward, I'm going deeper and deeper into the ear towards the eardrum. With forceps, sometimes you pull and it can remove a large segment of the skin, but some of the skin can be retained. But with suction, you can peel and pull, so it has a two-in-one effect. So again, I've just gone to the deeper part of the skin, trying to peel that off the anterior canal wall, the front section of the ear canal. Now, patients obviously say it was over the moon. There was a lot of this kind of bleeding because of all that granulation tissue, so just advise them not to get any water in the ear, not to poke obviously in the ear. I've just arranged a follow-up with my colleague Max. They live about 50 miles away. It's probably about 80 kilometres out, and that's the conversion. So it's not a million miles away, but my colleague Max can just kind of have a look in the ear, send me a video if need be, just to make sure everything's fine. Probably didn't really need to arrange that, but just to be on the safe side. And I've just advised this patient to attend every year to my colleague Max in the first instance, and if there's a problem and struggling, obviously just book in with myself. But if you catch it every year, before it gets this bad, and this patient has had an episode before, so they've got the silent chronic form, and so therefore they're going to have it again. It was about 4 or 5 years ago. So I just asked them not to leave it that long, because even in a year they're going to have formation of dead skin. So if we just clean it every year, just to keep on top of it, or sooner. Sometimes it can come back sooner, but I think years are good point. And there's a long tail of skin. Sorry guys, I've forgotten the knack to kind of record the skin as I'm coming out, or wax. It's something that I used to do initially, but I'm just so engrossed in the procedure a lot of the time now, I just kind of forget. I remember, I should have just slowed that down and had a good view as it's coming away. So there's a bit of blood collecting from that granulation tissue in the annulus region. So I'm going to go in with the fine end. The patient and I were both completely knackered at this stage, so I said, let's just get some of this skin out. Not skin, some blood. You can just see how much inflammation there is there, swelling of the lateral portion, the widening behind that, and it's the widenings all the way around. So I'm just attaching the fine end. Just going to get into the annulus, slowly suction some of this away. But I think it just kind of is probably going to refill. It's a bit of dead skin there. So there we have it. That's the patient's eardrum. It looks really good. And you're going to see another still image of, that's not all of it by any means, but that was that long tail at the end, I believe. Well, I hope you enjoyed that video, guys. Take care, keep well, and speak soon. Bye.